Go for it.
Wonderful. So I'd like to thank everyone for joining us today for our Family Medicine Grand Rounds. My name is Dr. Inez Cruz, and today is October 7, 2020. I'm going to be taking us through our CME required slides, and then I'll pass the torch over to Dr. Hyan. Our event ID for today is 281047. Of course, you can log in for our CME via cell phone, smartphone, computer. To be quite honest, our CME office is actually pretty accommodating. Next slide. We'd like to thank everyone for, of course, muting your microphones once the presentation begins, being attentive to the presenter. Today, Dr. Hyan has actually asked for those of you that are able to share your screen and actually turn your camera on, please do so. We feel like it would be a great welcome to Dr. Westfall for him to be able to see our reactions. Of course, being engaged in the session, Dr. Westfall has also identified that if you have burning questions along the way, please feel free to put them in the chat box. Please feel free to ask. We're happy to moderate so we can help with that. And then of course, at the end of the presentation, please complete your evaluations. Evaluations are important not only to the presenters, but also to Grand Rounds. Next slide. So of course, we provide our Grand Rounds with our educational partner, which is South Central AHAC. CME transcripts, of course, can be obtained via the Long School of Medicine CME office. It's as easy as calling in and then being able to obtain your transcripts later. We have some steps there for you. Next slide. Additionally, credit is offered through AAFP, so please make sure that we have your AAFP ID number so that we can make sure that you get credit. Next slide. And of course, we would like to welcome everyone to the Bellue-Holly Distinguished Visiting Professor. I am going to present Dr. Hyan, who is our department chair, and he will be introducing Dr. Westfall. Dr. Hyan.
Well, good afternoon and welcome to our Grand Rounds, and particularly the Bellue-Holly Distinguished Lecture today. Happy National Primary Care Week. This is a week where we take a moment to celebrate our contributions to the health of our communities and the health of our patients, and to really recommit to the values of primary care. This award is going to be shipped to you, and it's really a way of thanking you for your contributions and your participation. The Bellue-Holly Distinguished Visiting Professorship is funded by an endowment that was provided to us by Dr. and Mrs. Larry Holly to honor their parents and in-laws, and is a way of supporting the activities related to Primary Care Week. So we're very thankful for the Holly family for their generosity and their continual involvement. I'm not sure if Dr. Holly is going to be able to join us, but if he is, we welcome him and we're happy to have you here. It is a joy for me to introduce our presenter today. I have known Jack for many, many years, and he is he's a maverick, a dynamite, a very inventive, very creative family physician leader who has had a trajectory of great achievement, but with great sense of integrity to his mission, and to who he is. He's a family doctor now in Washington, D.C., and director of the Robert Graham Center for Policy Studies in Family Medicine and Primary Care. He will tell us more about the center in a few minutes. He completed his MD and MPH at the University of Kansas School of Medicine, and an internship in hospital medicine in Wichita, Kansas, and his family medicine residency at the University of Colorado Rose Family Medicine Program. He joined the faculty at the University of Colorado Department of Family Medicine, and he started what's called the High Plains Research Network, a geographic, community, and practice-based research network in rural and frontier Colorado. He practiced family medicine in several rural communities, including Limon, Lyman, Fort Morgan, and his hometown of Yuma, Colorado. He was in the faculty at the University of Colorado for over 20 years, including serving as Associate Dean for Rural Health, Director of Community Engagement for the Colorado Clinical Translational Science Institute, AHEC Director, and Senior Scholar at the Farley Health Policy Center. He just completed 2 years as a Medical Director for Whole Person Care and Health Communities at Santa Clara County Health and Hospital and Public Health Department. His research interests include rural health, thinking, primary care and community health, and policies aimed at assuring a robust primary care force for rural, urban, and vulnerable communities. Dr. Westfall is currently also the president of the North American Primary Care Group, and if you haven't signed up, please do. It's a wonderful meeting of the premier organization for primary care research in the world. And this year is going to be creative and exciting. Without any further ado, I am delighted to welcome Dr. Westfall. Thank you so much for being here.
Dr. Hyan and Dr. Cruz, thank you very much for inviting me to this. I'm really excited about this. It's delightful to join you. I think from let me just make sure we cover the necessary. I have no financial interests with or commercial interest to disclose. That's got to cover that to make sure everybody's good to go. So we're going to talk a little bit about primary care, COVID-19 response and recovery. You know, primary care has been out in the front on healthcare for years, and that hasn't changed in COVID-19 response and recovery. But, you know, there's not been a lot of media about primary care. There's been a lot of the heroes of COVID-19 and their ICU doctors and nurses and people in masks at the ER. And primary care has really not gotten a lot of media attention as being heroes in this COVID-19 pandemic. But we know differently. In primary care and in family medicine, we have continued to see patients. Our providers have continued to be available. The practices have tried to stay open despite poor funding, despite patients not wanting to come to the practice. And our communities have relied on primary care, both as a way to access care for COVID-19 or COVID-like illness, as well as all that other stuff that primary care does. So what I want to go through is sort of a comprehensive review of some of the stuff the Robert Graham Center has done over the last 9 months related to COVID and primary care. These are the objectives. This is for the CME. I want to just call attention to the fourth one. I just added that one. One of the objectives is that the participants will want to become a Graham Center visiting scholar. I'm going to put in a little pitch for coming to visit with us and work with us. Well, what is the Graham Center? The Graham Center, at its best, creates and curates evidence that informs policies to support primary care and family medicine. This is our team. We have sociologists and psychologists and geographers, PhDs and clinicians, economists, geospatial mappers. We work closely with Health Landscape. Their office is they share an office with us. This is the group. We have a year-long fellow, and we have 1 to 2 visiting scholars per month. I want to really put out a thank you to this team who have really done the work to produce the next 30 or 40 slides in this effort. So I'd like to encourage you to think about being part of the Graham Center. We have a visiting scholars program. It's 1 to 2 people per month. You come, it's virtual right now, but when it's in person, we have a furnished apartment in DuPont Circle. You work with our data and our research team, and you actually do some research, some policy research. And we also have a year-long fellowship. It's through Georgetown, and we're taking applications right now. So if you think you might want to be a fellow come August of 2021, email me or talk to Dr. Hyan or Dr. Cruz and get my contact info and let us know. I'm going to talk a little bit about some of the output of that group later on in the presentation. What I want to do now is turn to COVID response and recovery. As I said, the Robert Graham Center really uses secondary historic data to make future projections. So we look back and say, well, here's what primary care has been doing. Here's what family docs have been doing. How does that set us up for work today and for the future? Sometimes we have contemporaneous data, and I'll show a little bit of that as well to confirm some of the things that we found in our historical data as well. What we want to know is, how do we create what we want in primary care? Using this secondary data and this historic review, how do we then use that to leverage the future of family medicine? I'm going to talk a little bit about COVID response, what happened in the first few months, and then, keeping our fingers crossed for a COVID-19 recovery period. We're going to talk a little bit about what primary care would do in that. And as I said earlier, you all know, what does primary care do? Well, we do all the other stuff, acute and chronic, complex. There's a lot of other things, and we'll talk a little bit about that as well. I want to start with the car white box. I hope that many of you recognize this. This is a research that started in the 1960s by Carr White, a primary care physician. He found that using large data sets, that every month in a community, 1,000 people, about 800 of them have symptoms of an illness or injury. About 300 of them seek medical care. About 10 of them are hospitalized, and less than 1 is hospitalized in an academic medical center. This was reconfirmed in 2000 and by some others in subsequent years throughout both the United States and other parts of the world. What this tells us is that the bulk of research is done in that little tiny box at the academic medical center. And we wonder why it takes so much time to translate that out into the practice and the community. The Graham Center really tries to go out into those larger boxes to impact primary care and community health. Just for a little bit of level setting, does primary care really matter? Well, that bottom bar, the MEPS 2017, shows that every year, 53% of people in the United States go see a primary care physician. And if you take all of the ambulatory office visits in the United States, almost 50% of them, 46%, are to a primary care physician. Well, let's turn and look at COVID response. COVID is, early on was really a respiratory illness. I think we now know that there are some neurologic components and some hematologic components, but by and large, COVID is a respiratory illness. Well, who takes care of respiratory illnesses in the United States? This is from 2017, and you can see that the blue bar is primary care. Primary care takes care of respiratory, upper respiratory illness, bronchitis, even pneumonia. 9 million cases of pneumonia were cared for in the primary care setting, and less than 1 million cases were cared for in the hospital. There's no reason to believe that COVID-like illness is any different. People present with symptoms, they either call their physician, they show up at the clinic. Those people may very well have COVID because they have COVID-like illness. And we're gonna show a little bit of contemporaneous data that confirms this. And family medicine is a major component of primary care. Primary care total is in the blue, family medicine is brownish orange, and you can see that family medicine physicians provide lots of care for respiratory illness, COVID-like illness. Well, early on, we've been trying to get telehealth infused into family medicine for a decade or so. Many of you who have been on the leading edge of trying to do telehealth in your practices and in your residencies. It's been a slow go until March, when suddenly there was no one coming to the practice, and practices were having to convert. So we looked at, well, what's amenable to telehealth? What are the visits? So we looked at the National Survey of Ambulatory Medical Care, and we analyzed that based on the literature. What is there evidence for? Diabetes education, smoking cessation. There's a robust literature on what can be provided by telehealth or by phone or video. And then we also used some clinical sense based on the clinicians at the Graham Center, and we identified out of all those visits, about 42% of visits, of encounters, were amenable to telehealth. That's the encounters. If you look at the services that were provided, because often an encounter has multiple services, nearly three quarters of the services that were delivered were amenable to telehealth. And so there is a capacity for primary care and family medicine to think about how they best deliver care to maximize those that can be done that need an encounter, a physical encounter, and those that can be done by telehealth. Well, the flip point of that is that there's a whole lot of stuff that can't be done by telehealth. You can't do pap smear, and you can't do laceration repair or a cast by telehealth. So we looked at the reverse of that as well, and it's about 66% of the encounters. So while telehealth may be a really important component of primary care, telehealth cannot replace primary care. And I saw that there's a major insurance company who is trying to market a plan that's 100% telehealth, 100% primary care telehealth. And I just think that is not going to provide adequate service to those patients, because there's a lot of primary care that needs to be done in person. Well, let's look at some response in real time. We were able to get access to some data from a prominent electronic health record vendor. This includes about 45,000 family physicians over the 6-month period from January through July, 7 months. Now, the caveat to this is that we don't know which of these 45,000 physicians were actually billing during this time period. So this is the denominator universe is 45,000 physicians, but we don't know, we can't assign particular visits. I want to just call attention to the COVID tests in this sample. There were almost 1 million COVID tests done by family physicians, and over 1,500, almost 1,500 patients who had a COVID diagnosis. Here's what the patient volume looks like tracked over time. You can see the blue is the overall volume, and the gray is telehealth related. You know, from in February to March, it dropped significantly. And then in April and May started creeping back up, those total encounters, mostly because of the telehealth visits, but still there were quite a bit of in-person encounters throughout the United States. There were places where family docs continued to just keep seeing patients in person in the parking lot. And then you can also see that there's a rise in COVID-19 related diagnoses. And I think that that number is somewhere in the 400,000 per month range of COVID related illness. Here you see that sort of the in April, 295,000 cases of COVID seen in family medicine. In May, 377,000. And the telehealth visits, 700, 800, 700. July is only a partial month, but even in July, we started to see a decline in some of the telehealth and a return to more in-person visits. Certainly not a return to no telehealth. I think that's probably never going to happen. Well, what was being seen? Here are the top 10 diagnoses for the telehealth visits. You know that hypertension is a great disease for telehealth. If you have home blood pressure management, people can call in, give their numbers, you can talk about it, decide what to do. I want to point out number 2 and number 10, anxiety and depression. We've been concerned about this, and we'll talk a little bit more about it in a few minutes. But in terms of telehealth visits, those two were major players in how primary care was patients were accessing primary care. And then the great complexity of family medicine in the middle with diabetes and hyperlipidemia, very chronic pain, very common family medicine. Well, it's not too different from the face-to-face visits. Hypertension is still there. Interestingly, the number 2 was immunizations. So even in the midst of this, and with patients reluctant to come into the practice to get their vaccines, there was still a significant amount of vaccination and immunizations being given. So a lot of preventive medicine still going on in primary care and family medicine. 3 of those top 10 are respiratory: cough, sore throat, and URI. Undoubtedly, some of that is COVID-like illness and some of that's COVID. And then snuck in there in the top 10 also is another anxiety in a face-to-face visit. The Graham Center participated in a AAFP National Research Network survey. The National Research Network is hundreds of physician practices around the country, mostly family medicine, a few internal medicine and pediatrics. We did a weekly survey for 10 or 12 weeks, and then it's gone to monthly now. And we had pretty, interesting involvement. There were 225 practices that participated once, and then you see some of those practices participated 10, 11, 12 times. So we were able to track some of those things. We were specifically looking at financial concerns and treatment options. What were people doing for COVID? I'm going to talk a little bit about the financial concerns. Here are the prominent categories. Early on, it was around volume, patient visits. People were concerned about the volume of patients. Over time, though, that really morphed into concerns about financial strain. As those decreased visits related to decreased revenues, suddenly practices were having to lay off staff, put people on furlough, shrink their access, decrease their hours. Some of the family docs worked for free. I talked to one family doctor who cashed out his retirement so that he could continue to see patients and hire one nurse. The other thing that I think is interesting is the telehealth audio visual, the video telehealth was a big concern in those first few weeks. However, that really declined over time as people got used to it, as practices learned how to do it. It was less of a concern for those practices. Well, what if no one shows up? Early on, we were very concerned because people weren't showing up in the first month. And telephone calls weren't being reimbursed, or certainly weren't being reimbursed adequately. So in April or March, we made some projections about what would happen if telehealth and telephone visits weren't covered by insurance and what would happen. And at the end of March, there were 750 counties with a primary care physician shortage. And we estimated that over the next 3 to 4 months, without some sort of federal or some mitigation and payment, those practices could decrease their FTE, could close, and that by the end of June, there might be 1,800 counties with a physician shortage. Now, we didn't see that, but partly because the federal government did come in with some provider relief funds, advanced payment for Medicare, and some other loans, and then some rules and regulations related to telehealth and telephone coverage as well. So while we have seen quite a bit of decreased access, some furloughs and layoffs in primary care, we have not seen the closure of practices that we were worried about early on. I think this is something maybe near and dear to your department. It's the redeployment capacity of family medicine. And, family docs have a broad training and have comprehensiveness built into their DNA. And here we see that about 20% of physicians see patients in more than one setting. 75% see patients just in one setting, and most of that's in the office, but there's some hospitalists and some emergency department physicians. But for those physicians who see patients in 2 or more settings, only about half of that is in the clinic, and a quarter of it's in the hospital, some of it's in the ER. Physicians see, family docs see patients in the nursing home, even home visits. And so this redeployment capacity is really robust for family doctors to be able to meet the surge requirements in hospitals, particularly rural or smaller hospitals where the family docs are the primary providers in the community. They have the capacity to meet surge needs as patients are hospitalized. I think you all may have done this, and we're looking forward to hearing more about that in future conversations. Well, let's turn to COVID recovery. Dr. Cruz or Dr. Hyan, were there any questions during that COVID response period that you want me to address now, or shall I move on to COVID recovery?
One question that popped up, it said, I'm curious if you looked into or had data that could answer the question, how many telehealth visits resulted in an in-person visit, i.e. the visit issue could not be adequately addressed without the physical exam, labs, or other in-person activities?
Oh, that's a great question. And the short answer is, I don't know. You know, one of the things that we're advocating for at the Graham Center, we believe that that telehealth is really a new science and that we just don't know enough about it. Now, other people say, oh, we know telehealth, we know all about it, but frankly, we don't. The science of telehealth is really nascent and underdeveloped. And what we've been advocating is for the federal government, AHRQ, PCORI, NIH, HRSA, some of these agencies to actually put aside money to study how to do telehealth best. What things can be done by telehealth? What can't be done? Is direct-to-consumer telehealth adequate, or do you need to really support telehealth through the usual source of care? So I think I don't have an answer to that question, but I think over the next 5 years, we really need to study the telehealth as a separate science within primary care delivery. I'm going to move on to COVID recovery. You know, as we enter, hopefully, the recovery phase of this over the next 6 to 12 months, there's going to be a lot of things doing: antibody testing, serum testing, testing for the virus, immunizations, and then the whole rest of primary care services that need to be caught up. So let's look at who's been doing this. Well, this is Medicare fee-for-service data, and this is primary care physicians who do blood tests in their clinic. Now, they may not do the test in the clinic, but they draw the blood and send it to the reference lab. And you can see that in many counties, it's 25 and 50%, over 50% of the blood tests are actually captured in primary care. And that tells us that if we're really serious about serum testing and immunity testing in the next few months, you have to engage family medicine and primary care in those efforts. Likewise, immunizations. As we start getting a vaccine, how will you deliver that? And here we see again, a large proportion of vaccines are completed in primary care settings. And so any efforts at equitably distributing vaccines, immunity testing, is going to require active participation of primary care. Well, what about mental health? We were very worried early on about mental health. We know that economic downturns can lead to increased deaths of despair. We saw this in the recession of 2008. And so a group of us got together and said, well, you know, we are having some economic downturn, but we're also having this social isolation. And we don't know what impact that has. We believe it's going to have a negative impact on people's lives. And then the uncertainty. Every day a different fact, every day a change, every day a different recommendation. People's uncertainty about COVID is really leading to some anxiety and worry that can actually result in despair. And so we created some projections based on the economic downturn that we saw in 2008 and then the recovery of that. And we saw that we created some projections using a 1% increase in deaths of despair, 1.3% or 1.6%. And then we coupled that with the rate of economic recovery. So if you just take an increase in the middle, a 1.3% increase, and a medium rate of recovery over the next 5 years, you see that there could be 65 to 70,000 more deaths of despair from suicide and drug abuse. That's very concerning. And you can see in this map the counties that are most affected. Now, you'll wonder sort of what's going on in that great middle area. And this is really an agricultural Great Plains area that was less affected by the economic downturn of 2008. And so the projections we created were based on the evidence from the 2008 recession. And so we're not sure. We know that based on discussions with our agricultural friends and colleagues, there is an increase in deaths of despair in these counties related to the COVID. And so we're in the process of working with some folks in the agricultural communities to determine how best to evaluate the risk of deaths of despair in these more agricultural communities. This would be a great project for any of you who are interested in this. We're still trying to sort out the data sets and the analyses that we would do here. Well, who takes care of those patients? I don't know if you know, but this is National Primary Care Week. And so there on the top is the blue line. Primary care takes care of patients with depression and anxiety. Over the last 10 years, the bulk of patients with depression and anxiety are seen by primary care clinicians and physicians. Not that we can do this alone. Of course, we need our psychiatry colleagues, but the bulk of depression and anxiety is cared for in primary care settings. We also wanted to increase mental health awareness in contact tracing. So I know you all have done quite a bit in the area of contact tracing, and I think this is an area for a multidisciplinary effort where contact tracers are identifying people who may be at risk of getting COVID infection. Well, at the same time as they're making those dozens of calls a day, maybe they could do a short mental health screening and do screening, brief intervention, and referral for treatment to help not just decrease the risk of transmission of COVID infection, but also identify people early who may be at risk of mental health problems. Here we see just who does take care of those. Depression, anxiety, it's 44%. Look at the bottom, persistent mental illness. Even among people with severe persistent mental illness, a third of their visits are in primary care. Prescriptions, we write a lot of prescriptions for antidepressants and anxiolytics. Over half are completed by primary care. And this is even, yes.
We have a question in the chat box that says, what about the contributions of behavioral health consultants?
Oh my gosh. Well, yes, what about behavioral health consultants? Unfortunately, behavioral health consultants, we don't have a lot of data on behavioral health consultants. I will tell you that we have seen an explosion of telehealth behavioral health capacity, and for the first time, really, telehealth was reimbursed for counselors and behavioral health providers, and this has really improved access. You know, historically, telehealth was for convenience, and now we can use telehealth for access, and that's even more pronounced amongst behavioral health providers, particularly counselors and psychologists. And so that's a very important component of this that we have to think about as we move forward. And I think it's particularly important as we think about patient-centered medical homes and integrated primary care that includes behavioral health. So a lot of my work on primary care includes, I've stopped calling it integrated behavioral health and primary care because it's just too long. And my assumption on primary care is to assume integration of behavioral health into it. I know that's not true, but what we want to push is that there isn't a dichotomy of physical health and mental health. It's all one. And so primary care incorporates that as well. I know that's not an adequate answer to the question. I wish we had more data specific to behavioral health providers. We're working with a group called the Wellbeing Trust. I'd encourage you to look up Wellbeing Trust. We work with them quite a bit to think about how do we actually improve access to behavioral health providers. This is, I think, particularly important as we think about real patients. So patients typically don't just come with one condition. If you have just a mental illness, you are more likely to see a psychiatrist 60% of the time and 40% primary care. But if you have any other medical condition, diabetes, hypertension, cardiovascular disease, COPD, you are much more likely to be seen by primary care, and your care is much more likely to be in a primary care setting. And if you have 3 or more, it's over 80% of your care is provided by a primary care physician. I'm going to shift base a little bit and talk a little bit about hot spotting and cold spotting. You may all be familiar with Dr. Jeff Brenner, great work in Camden, New Jersey on hot spotting, identifying people who he called super utilizers who really have a high utilization of hospital and ER use. And he assigned them additional social services and primary care and enhanced primary care. And actually he found that they got better. There is a New England Journal article evaluating it that didn't find that. I had research was, I think, not quite adequate. Needless to say, hot spotting identifies individual patients and can dramatically improve their life. But it also sort of puts a price tag on them and reminds us that there are some people who cost us all more. And I'm not sure that's the best approach. You know, this is a map of Washington, D.C., and many of you may have seen this, and you can see that just a few subway stops apart, the life expectancy for people living there may vary from 5 to 10 years. Now, we don't believe that everyone in the middle of Washington, D.C. is a hot spotter, is a high utilizer. There must be something else going on. And that brings us to this concept of communities of solution and problem sheds. And we really try to think about what's going on in a community. What's the disintegration of social services and education and economics and food deserts? What are those things that conspire to create these cold spots, places where everybody's at higher risk of illness and injury? That's the cold spotting. And I think what Community of Solution does is look at that and say, what we want to do is engage the asset shed as well. What are the places and people that we can engage? The churches, the clubs, the primary care, the behavioral health providers. How do we engage them to create a community of solution to address those needs? You know, that sort of shifts how we think about population health. It's not the individual super utilizer. It's really, there's a whole lot of problem sheds. And how do we address those so that it's not just about individual patients, it's about the whole community? And how do we measure that? So we created something called, it's a little local community of solution index, and we lovingly named it the community PPE. Has a little bit of cachet right now, PPE, public health, primary care, and health equity. It's equal parts access to primary care, public health preparedness and resource capacity, and health equity is determined by the social deprivation index, which is a measure of county level social determinants of health. And we found this variation, this range. Each one of those is scaled 1 to 10. So the final scale is 3 to 30. And so you can see that across the country, there's a variation in this index based on primary care, public health, and health equity. Well, now the question is, what's the association between that index and health outcomes? We started with sort of a look at how does it relate to COVID? And here you can see there's an association between the index score and the peak cases per 100,000, with counties with a higher PPE index, that is, they have more access to primary care, more capacity in public health, and lower disintegration of their social determinants, have lower cases of PPE or of COVID. Now, that's not a surprise. What we want to start doing is looking at some of the intermediate outcomes, mask wearing and social distancing. Verizon has a great analysis where, because they have all these phones and mobile phones, they're able to access how far those phones are apart and how much people are traveling. And so they can determine social distancing at a national level all the way down to the county level. But then we also want to think about what are the other health conditions that have a shared responsibility and accountability between primary care and public health. Things like diabetes, tobacco cessation, obesity, places where the exam room is important, but it's necessary and not sufficient. We need to work with our primary care and our public health to address many of these issues, and this would be a way to measure how that works. Well, I told you I'd talk a little bit about scholars and fellows. They are very active, and I wanted to give some examples of things that they've done. We had a visiting scholar, I think he was a medical student, maybe a family medicine resident, who did a COVID timeline, CMS changes in primary care support. This is a timeline of policy changes that happened at the federal level over the last 6 months, and it was accepted at JABFM for publication. We had, not related to COVID, we had a sexuality-based education to prevent gender-based violence program, and that is a set of story maps. And then there was a commentary related to it that is published in the Lancet. We have a primary care chart book. This was a year-long fellow worked on this. It's 25 charts on primary care that everyone needs to know. We've done work on race-based medicine and language concordance, characteristics of office-based buprenorphine prescribers. That was published in JBFM. We have some that have ongoing analyses, rural practice, adverse child events. And then we have this portfolio of our research. It's just a sample, but we have a robust program on supporting women in medicine. We do a lot of work on telehealth. We have, I think, 7 projects that we have outlined over the next 6 months related to telehealth, workforce, and scope of practice. And rural and safety net. And if you're interested, please email me, jwestfall@aafp.org. So where does all that fit into the car white box? You know, it all sort of fits in from that community PPE, looking at that big box of 1,000, down to prevention and diagnosis. How do we care for people? And even into the redeployment in that hospital setting. I think primary care is a crucial component of the entire car white box in community health. I'll just leave this up for you just to think about, how do you pay for that? Is it fee for service? Is that the best way? Is that the best way we can do it? And I think COVID has reminded us that the answer to that's no. Fee for service is probably not the best way to think about primary care. I want you to think beyond just medical payment and think about, what about public health and social services and all of those other funding streams that impact people with the social determinants of health and health equity and public health? And how do we make sure that all of those funding streams receive the resources they need to help primary care succeed? This is some of the necessary references from the work we've done. And I am happy to take a few questions. I'm going to stop sharing so we can see people.
So we'd like to open up the discussion and see if there are any questions.
So I have a question. This is Mark Nato. I'm the residency director. From time to time, I've talked to medical students, residents who say they want to be like you, like they're interested in policy and they're interested in public health research. So what's a good entree for somebody at that level of their career to try to be like you?
Well, I hope you mean you with a capital Y. It's you as the royal you, I assume. And it's very, you know, my career, I started medical school and I'd gone to a small liberal arts college that all the tests were on blue books. And, you know, we explained what we were doing. And I got to medical school and I was devastated by the testing and the evaluation and these 1 if by land and 2 if by sea questions. And, you know, everything was on Scantrons and you couldn't explain. And if you didn't get all 4 components right, I almost flunked the first year of medical school. And so I decided I wasn't sure if this was right for me. And I took a year and I did a year of a master's in public health to see, and it did convince me to go back to my rest of my medical school. And so I finished that, but clearly, but it really piqued my interest in public health research and epidemiology and policy. I think any experienced students can have in thinking beyond the exam room. My son's a medical student. I say, you know, you really have to become the best. You're in medical school, you're paying to be the best doctor you can. spend time in the exam room, spend time with patients. On the other hand, there are periods of time throughout medical school between first and second year, during fourth year, where you can explore some of those other options. And I would strongly encourage people to consider doing a month or two at the Graham Center, or I did 6 weeks at the CDC, somewhere where the work is outside of the medical care. It's the other groups of people who care about the well-being of our patients, because it expands their horizon. And then I think, once people get into residency, there are some requirements around community health, and I think residencies can really think about trying to make those cool, not just a checkbox. And I know that there are residencies where it's a checkbox. You have to do this. We don't put much resource into it. And, I understand that there are constraints, but when you have the opportunity to provide those students with an opportunity to get outside of the clinic, I think that's a good way. It's their experiences. Does that answer your question, Mark?
Yeah, that's great. Thanks a lot. Appreciate that.
Dr. Nato, to kind of turn that question back to you, would a time or placement with the center be something that would be eligible for us as residents for an elective credit?
So there are many interests that are involved with that question. So if you're interested in something related to that, I would put together a proposal, and then we'll discuss, all issues related to that. There's issues related to, the travel and the funding and the insurance and all that. So there's many competing issues since you're an employee here as well as just a student. So, but we could work on that.
And I'll just pitch in there, for the time being, all of our rotations are virtual, which has allowed a little bit more capacity for people, for particularly family medicine residents, to participate, because it doesn't interfere with their clinic requirements. They don't have to do it as an away month. They can do it as they can stay seeing patients their minimum number of half days. And so while we're still virtual, and my guess is we will maintain virtual forever now for some of our scholars, it may be an opportunity, because then you don't have to take it as an away month.
That's an interesting idea, because I think in terms of travel, the time away, the expense, and all the other issues, that makes the lift not quite as heavy.
Yeah, so for the virtual or the in-person, just FYI, we have funds for, we have a furnished apartment and we have a meal stipend. So people just have to do the travel. But still, with the virtual, it does expand the access.
Yeah, living in DuPont Circle sounds pretty good. That's a nice area.
It is sweet. You're, walking distance to the Lincoln Memorial. What more could you want?
Could you say something about your experience being an AHEC director, and how does that connect with some of the things you're doing?
Yeah, so my gosh, I didn't realize this is sponsored by AHEC, and I'm a AHEC aficionado. I loved AHEC from the time I learned about it, and became the Colorado AHEC director for a number of years when I was the associate dean for rural health. And we did lots of pipeline programs. And I think, for me, AHEC, and in Colorado, AHEC was largely rural based. And so it really helped me get out and about. And I think AHECs are really this robust resource. We used to say it's the best kept secret on campus and in Colorado, because a lot of people didn't know, but we were interacting with every single student. We were placing 600 or 800 student months a year out into rural communities. And I think it does a couple of things. One, it's really good for the students to see life outside of their usual setting, the university. Two, it's really important for community members to see young health professionals in training who are committed to working in rural. And it was an important part of my sort of life for a decade, as I thought about how do we assure an adequate workforce, So a lot of the research we're working on now is related to workforce, the research, and then rural particularly. So that experience as an AHEC director really helped inform my research on rural health services. Is there an AHEC director in the house?
I don't believe that she's on the call, but we've got a good relationship with the AHEC here and have worked with them closely for many years, and they play a big part in our community medicine rotation.
That's awesome.
Another question?
I had another question that was sent to me from Dr. Ramos regarding the continuity of care. I'm sorry, a gap in access for follow-up cares for those that have completed COVID isolation. Dr. Ramos, did you want to expand on that?
Sure. Can you hear me?
Yes.
Yes.
Okay. So I trained in occupational environmental health and occupational medicine kind of over the last 20 years has lost its luster or maybe its need. But occupational settings that I was brought on to help a couple of companies set up their internal surveillance for COVID, those who had tested COVID in their workforce. And although the access to the testing was not an issue, the follow-up care to those that continue to experience COVID symptoms, even though they've completed the isolation period according to the CDC criteria, has been a challenge. Their partnerships often for testing often are with urgent care clinics. So, but those are not long-term solutions, obviously, to this evolving chronic COVID syndrome. I just don't know what else to call it. They initially thought the right thing to do was call the health department, and the health departments would say, well, thank you for letting us know, but we don't see patients. So they've been at a loss. So, locally, I've been referring them to just, if the employees don't have a continuum of care or PCP to seek the process of becoming impaneled at the FMC clinic at the Robert B. Greene here in San Antonio. But for the company locations that are in the jurisdictions outside San Antonio, rural South Texas, or even rural counties in other states, I feel that this could be a good opportunity for FP growth. It's a new area, to kind of reclaim occupational medicine. Well, at least where I trained, it was embedded in family practices, maybe kind of return to the olden days. But there is a need, and I don't see that this chronic COVID syndrome is going away soon. In fact, it's becoming more and more prevalent, and there are even isolated reports of individuals developing or being diagnosed with COVID with a different genotype, a different COVID species. So I don't know. I just wonder, this is this whole issue is evolving so quickly, and for consultants like myself, what do you suggest? I mean, I think that it's a great referral, but it offers an opportunity for family practice to get involved in the conversation regarding the long-term impact of COVID and just what can be done about it. I don't know if it will.
Dr. Ramos, I think you are hitting a really important factor, and I think this is one of those places where I think our work with employers and employer-based insurance can really help family medicine and primary care. I think a lot of people in America, especially young employed people, between I'd say 20 to 40, don't know they need a doctor. They don't think about it, and they probably don't need a doctor, but they probably need a relationship with a practice. So they may not need to go in every year, but they probably need to know who they can go see. And as you said, get impaneled, or at least start that relationship so they have a place. And I think family medicine can work with employers to try to make sure large employers who have multiple sites of business around the state or around the country have access to the local primary care providers so that they can refer people and have a relationship. And a lot of what I do is to try to build relationships, and I use data to leverage relationships. And I think what we can do as family medicine is reach out to large employers. I worked in Fort Morgan at the community health center there, and we had a strong relationship with the local meatpacking plant that employed probably 400 or 500 people. And we had a strong relationship with them so that they knew any of their employees could come see us. That was sort of the standard. So everybody that worked there knew we were their doc, we were their practice. And I think that's, as we think about following up with chronic COVID syndrome or following up after quarantine for the other things that people need to follow up and make sure they're doing well, building the relationship up front is going to be really important.
Thank you.
I think the last final question that we had was just what approaches do you foresee will be effective in ensuring equitable access to immunizations once a COVID-19 vaccine is available?
Yeah, so there's the National Academy of Medicine, I think, put out a paper specifically on an equitable distribution of COVID vaccine. And I've reviewed it briefly, but I haven't done it in detail. I don't know, Dr. Hyan may, or Dr. Farrer, as NAM members may know more about that, but I'm just gonna pitch in before they talk and say, any immunization distribution, it will be unsuccessful if it doesn't include primary care. Dr. Hyan or Dr. Farrer, do you have?
No, I would say there's a lot of conversations around the country about how to make sure that it's equitably distributed, including a large research, hastily constructed research effort by NIH. So I think we'll be learning more about that as time goes on, but it's clearly critical because otherwise we'll just mirror history, one more time. We don't want to have that happen.
And the new document is available free for the download from the National Academy of Medicine website. So it's been published in the last few days. Well, Dr. Westfall, thank you so much. We were very, thank you for your enthusiasm and breadth and exciting. We are delighted that you were able to present to us, and we look forward to your Friday morning opportunity to continue this conversation.
Thank you all very much, and I look forward to visiting in person sometime and meeting some of you either in San Antonio or in Washington, D.C.
Bye-bye.
Thank you so much, Dr. Westfall. Please remember to complete your evaluation. We look forward to seeing you.